Good afternoon, everybody. Thank you so much for joining us. Yes, everybody is automatically muted, so that will remain the case throughout our session. So we'll be getting started in a minute. We just have a few more people that are climbing on the session with us. So I'll just give it another minute or so just to let everybody enter, and then we'll start the session. And again, thank you to those that have joined already. Thank you so much for being with us. And just to let everybody know, we are recording this session, so we'll be able to post it on our website for those that were unable to attend. Dr. Jansowitz, I could have, I could send you a Northern Light Health branded virtual background, although I like what's going on in your office there.
You have, right now you have some old certificates and diplomas and a little bit of my scattered mind behind me, but feel free to send me a background, and there's probably about a 50% chance that I can figure out how to get it going in Zoom.
No, I think you're perfect just the way it is.
Thank you.
That's just fine. Like look at the photo of Eastern Maine Medical Center behind me.
I love it.
Isn't that something? Yeah, one of our patients took that and sent us along. Look at the reflection on the river is beautiful. She was actually, I believe she was fishing with her grandson while she took that photo. So that's pretty cool.
Yeah, it looks like it's right across the river there in Brewer. Very cool.
Yeah. Okay, we are a couple minutes after 12. So I wanted to say thank you to everyone who's joined us. Thank you so much to Dr. Mansour and Dr. Jansowitz. My name is Amy Kenny, and I'm the manager of marketing and communications for Northern Light Eastern Maine Medical Center. And I am so glad you're here with us to talk about heart care, prevention, and wellness. Just a couple little quick housekeeping tips before we get started. As we mentioned earlier, this session is being recorded, and everyone will remain muted, except of course for our presenters. So you will be able to ask questions by typing them into the chat box. And Dr. Jansowitz has agreed to monitor the chat box, and will probably interrupt Dr. Mansour when needed, or else wait until the end of the session. So again, today's agenda, we're going to talk about lipids and cholesterol and heart care, and it couldn't be a more important topic for us as we move through our days. So it's going to be a great session. So Dr. Jansowitz is one of our cardiologists who will be monitoring the chat. At the end of the session, everybody, there will be a survey that pops up, and we would ask that you complete that survey for us. And so now, without further ado, I want to welcome Dr. Mansour. Thank you so much for being with us today. And I have a few words to speak about our number one, Dr. Mansour here. Dr. Mansour started with Northern Light Cardiology in August of 2018, so almost 4 years ago now. He is a non-invasive cardiologist. He performs transesophageal echocardiograms, interprets echocardiograms, stress tests, PET CTs, cardiac MRIs, and treats all types of cardiac patients, including heart failure patients. Dr. Mansour received his medical education at the University of Jordan Medical School and completed residencies at National Health Services in United Kingdom, Oxford, and East Anglia Deaneries. Did I get that right? Is it close enough, Dr. Mansour?
Close enough.
I know, we practiced that last week, didn't we? And Riverside Medical Hospital in Ohio, and also completed a fellowship at Allegheny General Hospital in Pittsburgh. So that is you, and we are so glad you're here. So if you would like to just take it away, we're here to be educated.
Thank you so much, Amy. Thank you for that introduction, and good afternoon, everyone. And thanks for giving me the pleasure of really presenting this important topic, especially when it comes to cardiovascular disease. And the reason why is cardiovascular disease, as we will see in the next slide, is really very prevalent. It's the #1 killer of people in the US, in the world, and especially here in Maine. Back in 2017, there were approximately 650 to 700,000 deaths caused directly by cardiovascular disease. Deaths related to cardiovascular disease are more than lung disease and cancer combined. As I said, it's very prevalent. Approximately 7 to 8% of the US adult population has some sort of coronary disease. Approximately 3% have cerebral vascular disease that could be in the form of mini strokes or even strokes. And we can also put heart failure with these patients. So we can see when the numbers kind of add up, really approximately 20% or so of the US population it has or is at risk of developing cardiovascular disease. And there's also a big economical burden when it comes to cardiovascular disease, where approximately, and this is back in 2017, so it's probably ×2 now, the direct and indirect costs to the economy was approximately $360 billion. So we can see that it's prevalent and really has a massive effect on the health of the general public, as well as a big effect on the economy. So this talk is more, it's not just about hyperlipidemia, it's also about talking about other risk factors briefly, because they all come together. So when we look at cardiovascular risk factors, we like to group them up to modifiable risk factors and non-modifiable risk factors. The non-modifiable risk factors are age. We can't do anything about aging yet. And also the genes that we inherit from our parents. They can either put us at an increased risk of developing cardiovascular disease or reduce our risk of developing disease. And then there's other modifiable risk factors such as smoking, diabetes, hypertension, unhealthy diet, being overweight, leading a sedentary lifestyle, having a lot of stress, excessive alcohol intake. All these do increase our risk of developing cardiovascular disease. So our talk is mostly focused on hyperlipidemia or high cholesterol. So basically, what are lipids? Lipids are fats that are present in our bodies. We can produce them, or we can take them in from our environment, from our diet. And basically, they are an organic group of compounds. They're predominantly made of carbon, hydrogen, and oxygen. And the common feature of lipids is they're insoluble in water. So what kind of fats do we have in our bodies? There's three major groups of lipids in our bloodstream or in our bodies: triglycerides, cholesterol or sterols, and phospholipids. Triglycerides is one of the commonest lipids that we have in our bodies, and they're the ones that we generally get from our diet. We can get triglycerides from unhealthy, or let's say from healthy sources, and also less healthy sources, such as dairy products and meat. And we commonly call triglycerides, or they commonly present as fats and oils. And the big difference between them is how do they behave at room temperature? If they're solid at room temperature, then they're usually fats. If they're liquids, then they're oils. And this is what the chemical structure looks like. It has a head called the glycerol head and has three fatty acid chains attached to it via an ester bond. And basically, when we digest it, the whole aim is to break that into smaller particles that we can use to mostly generate energy when it comes to triglycerides. The other common group is the sterols, and the most important and common sterol is the cholesterol. And most of the cholesterol in our body is actually produced by our livers. We only get a small amount through the diet, but it's still an important factor. Cholesterol is anonymous with atherosclerotic heart disease, but it also has a lot of, provides a lot of benefits and has a lot of important jobs in the body that we'll talk about later. And this is the structure of the sterol. As we can see, the big difference is there's 4 rings, and these rings are what make it a steroid. And then we've got some, like an antenna, which is formed from different carbon atoms. The last major group is the phospholipids, and they're very important as well. They play a major role in forming the cell membranes in our bodies. And we can also get them from our diet or can be produced in the body. And this is what it looks like. So this is a cross-section of the cell membrane, of the barrier of the cell. And basically, it looks like a head and a tail, and we can see there's 2 layers. And the heads are what we call hydrophilic. They like water. The tails are hydrophobic. They want to avoid liquid. And on both sides of this layer is liquid. We have this cytoplasm, which is the liquid inside our cells, and we have the extracellular fluid on the outside. So it forms a nice barrier. We can have different proteins in there. We can have cholesterol in there, and they all play a different role. So these are the major groups, but as we said, lipids are insoluble in water, in solution, in plasma. So for us to carry them in our bloodstream, they need to be coated by a layer which is hydrophilic. And we have what's called a structure that's called a lipoprotein. And a lipoprotein looks like this. Basically, the fatty substance, the insoluble substance, the cholesterol, triglycerides are on the inside. And on the outside, there's a shell that's made of phospholipids, as well as proteins called apolipoproteins. And there's different kinds of lipoproteins in our body. There's 4 major kinds. And the kind depends on what's inside. Is it rich in triglycerides, the fatty acids, or is it rich in cholesterol? So the first one is called a chylomicron. So the yellow basically is triglyceride, the yellow dots inside, and the blue dots are cholesterol. So we can see it's a big, big particle. There's certain proteins, which are the red, and a lot of triglycerides on the inside. The structure next to it is called very low density lipoprotein. And we can see there's more blue dots. It's a smaller particle, so it carries more cholesterol, carries triglyceride, the yellow dots, but less than the chylomicrons. And then we go to our typical cholesterols, the LDL cholesterol, the low density lipoprotein, which has no triglycerides, so has no yellow dots inside, is mostly made of cholesterol. And then there's the high density lipoprotein, which is also formed of cholesterol, but less than the LDL. So what tends to happen is the chylomicrons are absorbed, or we take in our dietary fat, it's absorbed, and we end up with the chylomicrons. The very low density lipoproteins underneath is predominantly made in the liver. And the function of both of these, the chylomicrons and the very low density lipoprotein, is to get the triglycerides, the yellow dots, inside the bloodstream so that the body can use the triglyceride in various pathways, but ultimately and mostly to produce energy. And then once the triglycerides are out, using an enzyme called lipoprotein lipase, which is in the wall of the vessels, we end up with the LDL, which we typically think of with atherosclerosis, as I mentioned. But it also has benefits. So an LDL can help build and maintain our cell membranes. So it maintains the integrity of the cell membrane. It's also taken up by the liver to produce bile salts, and we use bile salts to digest and absorb fats. And what's left in the periphery is taken up by the HDL, or becomes an HDL, which takes it back to the liver. And the way that we think about it, LDL is bad, it's the bad cholesterol. HDL is a good cholesterol because it's taking it away from the periphery, it's taking it away from the bloodstream into the liver to be manufactured to other compounds. So why are lipids important for the human body? So as we mentioned, triglycerides is the most common dietary fat that we take, and we have a big storage of fat in our body. And it's basically mostly used for as an energy source. So we have two energy sources, more or less, inside the body. We have glycogen, which is made from glucose, from carbohydrates. But the problem with glycogen is we're only able to store so much. So it's the one that we typically use first before we go into fat supplies, but it's a very efficient source of energy. And then the other energy source is the fat storage, the adipose tissues. And basically this energy supply really is limitless. We can supply an indefinite amount of fats in our fat cells, in our adipose tissues. So, so that's one of the main functions of lipids. The other important function is regulation and signaling. So cholesterol and phospholipids play a very important role in making our cell membranes, in maintaining the fluidity of the cell membranes, in maintaining some rigidity, some shape for the cell membranes. It can also help with in signaling with other particles. It can interact with various molecules as well to perform different jobs. Another very important job of cholesterol is making hormones, steroid hormones. The most common hormones that we have are testosterone, progesterone, and estrogen. These are the sex hormones. But it also plays a role in producing cortisol, our stress hormone, as well as aldosterone, which is important, especially from a cardiac standpoint, in blood pressure, heart failure, has different interactions in the body. Fat is also important for insulation and protection. So when we think of fat, we can think of it as two layers. We have the inner layer, the visceral fat, which surrounds our organs. So prevents it, like it cushions it from trauma. And then we have the subcutaneous fat underneath our skin, which plays a very important role in temperature regulation, insulating us from our environment. And lastly, another very important function of lipids is it helps digest more fat, helps us get certain products from our diets, such as very important products called phytochemicals, which are found in vegetables and fruits, such as lycopenes from tomatoes, beta-carotenes from carrots. And it also plays a major role in helping us absorb various vitamins from our diet, the fat-soluble vitamins. And these are the ones that are involved: vitamin A, D, E, and K. Vitamin A is the one that's involved in good vision health, reproductive health. Vitamin D is important for skeletal and bone strength. E is important for the immune system. Vitamin K is important for blood clotting. So as we can see, I mean, lipids are important. We can't live without lipids. And they're so important that actually our body produces most of the cholesterol foods. That too much.
Anas?
Yep.
Hey, can I interrupt for just a quick sec? So it looks like you're going into a nice transition phase here that was a tour de force, a wonderful explanation of why we have lipids circulating in our body, where they come from, the gut, the liver, and now we're heading into the part how they can be harmful. I just want to encourage people to ask feel free to ask questions into the chat panel if you have questions about that first part of the talk, because, just that was a wonderful summary of, why do we have something that can be harmful potentially in excess or with genetic, just different genetic markers, et cetera. How can something that is that we need be harmful? That's the next step. But we've heard why it's there, and now we'll move on. So thank you so much, and I look forward to this next part as well. And I will monitor for questions. At this point, no questions yet, but I'll let you know if there are.
Sounds great. Thank you so much, Alan. So so the second part is the harmful effects of lipids. So when we look at the harmful effects, I always try and divide them into two major groups, the triglycerides as well as the cholesterol. Now, there's also other particles that we're not going to talk about today, but they do have a role in atherosclerosis, such as lipoprotein, Ldl. They play a bit of a role as well with atherosclerosis. So triglycerides can have an effect on the cardiovascular health. They can cause some thickening of the arterial walls, so arteriosclerosis, and can increase the risk of heart disease. The other thing that we are always cautious of, especially when the triglyceride levels get really high, especially when we're talking about 500, above 1,000, is triglycerides can cause an illness called pancreatitis. And basically what that is the pancreas, which basically helps us digest fat through an enzyme called lipase. For some reason, these enzymes start getting activated inside the pancreas and start digesting and eating up this pancreas. This can be a very painful condition, and unfortunately can be a lethal condition as well. And that's why really when triglycerides are really high, we need to be very aggressive about bringing them down. And in a later part of the lecture, we'll talk about lifestyle changes that we can do as well as medication changes. So the other thing in regards to the triglycerides can be a marker of an entity, a constellation of symptom signs called the metabolic syndrome. So metabolic syndrome basically has the person with the metabolic syndrome typically is overweight. They have a lot of truncal obesity. The sugars tend to be on the higher side. They tend to have higher blood pressure. When we get a lipid panel on them, what we notice is their triglycerides are high and the HDL, which is a good cholesterol, is low. And this can be an early marker that the person is at risk of developing overt diabetes, is at risk of developing overt cardiovascular disease. So triglycerides can be a marker of this condition. So what's the normal range of triglycerides? So we usually say the desirable range is less than 150 milligrams per deciliter. Borderline is about 150 to 199, and high levels, increased levels are between 200 and 500. About 500 is very elevated. The important thing to know with triglycerides, when we want a more accurate idea what the numbers are, it needs to be a fasting lipid panel. A non-fasting lipid panel, if you just ate and went and had your cholesterol checked, your triglycerides will be elevated. So ideally, we want an overnight fast and then get in the blood test, and then we'll have a more accurate picture of what the true triglyceride numbers are. The other cholesterol is the LDL or the low density lipoprotein. And this is dangerous, especially in excessive amounts, because this is the one that can accumulate in the walls of the vessels. This is the one that causes plaque buildup, which with time, as it grows inside the lumen of the vessel, it can cause reduced blood flow, which can cause issues such as chest pain, angina, when it involves the heart vessels, the coronary vessels. It can cause claudications, which is pain in the legs when you're walking or when you're active. Sometimes it can also restrict blood flow to the brain, can cause a stroke. Or what can happen is you can have a small tear of this plaque, and that can cause your different cells in the bloodstream to kind of attack it, accumulate on it, and that can cause complete blockage of the vessel, can cause an acute heart attack, or what we call a STEMI, as well as an acute stroke. And what we look at, so actually I'll come back to that slide. So this is just a cartoon of what a normal vessel looks like at the top. So these red discs are red blood cells just floating around. The one underneath is when we have plaque buildup. We can see there's a lot of cholesterol, that's a yellow color. And it starts encroaching onto the lumen and reaches a point where it can cause and limit blood flow and can cause symptoms. And the last one underneath shows a rupture, and where we have complete occlusion of the blood vessel. This is another diagram, exactly the same. So we have buildup of plaque, it keeps growing. With time, what tends to happen as well is the inside of the plaque, the cholesterol kind of changes. We get inflammatory cells, we get scar-forming cells inside, and the plaque, instead of it becoming soft, the yellow plaque, it becomes more of a complex plaque and a bit harder. And these tend to be a bit more stable. Patients with these, for example, when it comes to the heart, they present with angina. While the soft plaques, what we worry about is we worry about them rupturing. They're the ones that are typically involved, well, most of the times can be involved with acute heart attacks and acute strokes. Going back when we're talking about levels, what normal levels are. So an important thing to know is it depends on the person. It depends on, because what could be normal in my case could be really abnormal, could be really high in, let's say, Dr. Janzowitz's case. So a healthy person, let's say 40 to 50, a young man like Dr. Janzowitz, no medical conditions, an LDL between 60 to 130 can be regarded as normal. 130 to 159 is elevated, is borderline elevated. And when it reaches 160 and above, then that's high risk. That's when, even if the person is healthy, if they have certain risk factors, then we want to try and treat that with lifestyle changes and then with medications. And we'll get back to that. So this is just a cartoon of a plaque buildup in the carotid arteries, and that can cause a stroke. And this is another cartoon of plaque buildup involving the arteries in our legs, which can cause claudications or pain when we're active. Sometimes, similar to when the plaque, when you get the black tear and you get the complete occlusion in the heart, you can get the same thing in the legs. A clot can break off, can travel down to the feet, can cause gangrene, for example, an ischemic limb. And this can be an emergency that needs to be quickly acted upon. In men, peripheral vascular disease or significant hyperlipidemia can result in erectile dysfunction as well. What we need to know is, it's called a vascular tree, because if your heart's involved, most likely you have disease elsewhere. So what can I do to reduce my risk of cardiovascular disease? So there's different things that we can do. So we need to really attack, modify, and reduce our risks. So if you smoking cessation could be one of the best things that you can do. Healthy diet that we'll talk about in more detail. Regular exercise, maintaining healthy weight is critical. Keeping your cholesterol under good control, controlling your sugars, monitoring and controlling your blood pressure, limiting alcohol and salt intake. These are modifiable risk factors. And they can be just as powerful, if not even more powerful, than medical therapy. So when it comes to the diet, really, I'm kind of partial. I'm from the Middle East, so I'm in the Mediterranean basin. So a Mediterranean diet, especially a plant-based Mediterranean diet, is the healthiest diet out there. In the past, we went with low-fat diets, and somehow we substituted low-fat with high sugar, and we realized actually we were causing a lot of harm. So really, a Mediterranean diet is the best diet out there. It's sustainable, it tastes good, and it's full of different nutrients that your body needs. So what it is basically plenty of fruits and vegetables, aiming at least 5 units of these a day. There's whole grain, so you try and avoid processed, simple carbs, refined carbs, which is rich in our Western diet. Use a lot of legumes, you use a lot of seeds and whole grains. The other important thing about the Mediterranean diet, or what common in the Mediterranean diet, is there's a big role for seafood. Fish, especially oily fish, is very helpful. Poultry within confined to about 1-2 times a week is okay. Eggs, dairy products in moderation is healthy and recommended. Really, the things that we need to try and cut back on is red meats, and of course, refined carbs and sweets, candy. Try and avoid completely, or if you're someone like me who enjoys a piece of steak every now and then, maybe once a week, once every other week, it should be okay. Substituting soda, fizzy drinks with water. Coffee in moderation is actually healthy. And also cutting back on alcohol. Here it says alcohol in moderation, but there's been newer studies out there that mention even a small amount of alcohol can have harmful effects on them. I usually tell my patients, I mean, if you're someone who enjoys a glass of wine with dinner every now and then, a couple of times a week, it's absolutely fine. It's important to avoid binge drinking. And then, of course, there's a role for regular exercise activity. So this is a picture of what healthy fats look like. And I mean, it looks appetizing, plenty of nice colors in there. So you have your oils, mostly olive oil. You have your oily fish, the salmon, mackerel, sardines, a lot of nuts, healthy fats. So just looks great. The other thing we need to know is, even with healthy fats, they are high in calories. So we need to be careful that we're not having too much in our diet. So it's usually recommended to get about 20 to 30, 35% of your total calories from healthy fat sources. About 50% is from carbohydrates, but healthy carbohydrates, and about 20 to 30% from lean protein, ideally. So that's just a quick look at the importance of diet in reducing our risk and also improving our cholesterol. Another important question is, when do we need to get our cholesterol checked? So really, it's important to at least have it checked once when people are young. Usually it's recommended around the age of 10 to have a first lipid panel evaluated. And the reason is to make sure that the child hasn't inherited a genetic disorder that causes significantly elevated cholesterol. Because if they do, most common one is heterozygous familial hyperlipidemia, which has an incidence of about 1 in 300. So people are born with significantly elevated cholesterol, and even as youngsters, they can have really, really high cholesterols, and it starts building up in the walls of the vessels early on in life, and they unfortunately present early in life with heart attacks, with stroke, and just really nasty disease everywhere. And that's why it's important to have that first lipid check early in life, because really with aggressive lifestyle modifications, and in some patients, even early use of cholesterol medications can really have a big benefit and can really reduce the risk of cardiovascular disease down the line. If the cholesterol was okay when we were children, then it's recommended to repeat it again between the ages of 18 and 21. So just after high school, just to see where we are. And if your numbers look okay, then it's recommended to have a lipid panel checked every 5 years thereafter. Until we reach middle age, 40, 45, then ideally we should check our cholesterol more regularly every 1 to 2 years. If we develop any other medical conditions, if we're diabetic, high blood pressure, or if we're at a high risk, we smoke, we have a strong family history of heart disease, then more frequent testing is recommended. So what's normal, what's abnormal? So this table shows us what the ideal numbers are. But then again, if we look at the LDL, it really depends on the individual. So the desirable LDL of 130, for example, in a patient with coronary disease, someone who's had a stent, someone who's had a heart attack, someone who's had a stroke is actually too high. In this population, we want the LDL to be less than 100, ideally less than 70. And there's a growing movement to even bring it down to less than 55 as they're doing in Europe. What we found out with time is the lower the LDL, the better. There's no too low LDL. In the past, we used to worry of having really low LDLs affecting our neurological status, our mental development. But when we think about it, children, when they're born, they have really low LDLs. The LDLs are in the 30s, 40s, and they develop normally. So new research, new data shows actually it's safe. Having an LDL of 40 is actually safe for mental well-being, for neurological well-being, and it actually really reduces the risk of future cardiovascular disease. So this is a busy slide. This is a very, very busy slide, but it's really a very important slide for providers, because we typically use this slide to assess the risk of our patients, to try and categorize them, try and know where do they stand and how aggressive I need to be. So there's certain conditions where, regardless of your LDL, we want to try and have you on a statin. So this mostly involves statin therapy because it's really a class 1 indication. It's the one that's been mostly studied and has shown most benefits. So if your LDL is above 190, so you're already at a really high risk of developing cardiovascular disease, even if everything else is within normal limits. You're not diabetic, your blood pressure is perfect, you don't smoke. Just having an LDL above 190 is a significant risk factor for coronary disease. So what we do is we recommend lifestyle changes, and we ideally should put people on high intensity statins. When it comes to high intensity statins, we usually use one of two, Crestor and Lipitor. Crestor, we use a dose of 20 to 40 milligrams, Lipitor 40 to 80. If you're diabetic, then we need to use a statin, because diabetes really accelerates the risk of atherosclerotic disease, cardiovascular disease. So we need to be very aggressive about reducing the risk. And then the other thing that we look at is, so that was the top right of the slide. And then there's another thing that we look at is based on age and based on something called the ASCVD risk, or the atherosclerosis cardiovascular disease risk. And this is just a calculator. I wanted to say a fancy calculator, but really it isn't. It's just a couple of numbers that we plug in, and it spits out a 10-year risk of cardiovascular disease. But basically going to the slide, so if you're between the ages, or you're less than, let's say, 19 years old, and you have high cholesterol, let's say you're 160, 170, 180, then ideally we just recommend lifestyle changes. once you hit the 190 or there's a known family history of familial hyperlipidemia early on, we would try and treat you with statin therapy along with lifestyle changes. Ages between 20 and 39 are threshold in treating goes down. So if your LDL is above 160, you have a risk factor or you have a strong family history of early, let's say, heart disease, then we would consider early initiation of statin therapy. And then really where this ASCVD risk was studied and gives us really the most bang for our buck is between the ages of 40 to 75 with an LDL range of 70 to 190. So as I said, we put in some numbers and it gives us, let's say, my risk, let's say, is 5 to 7.5% risk of developing significant atherosclerotic disease over the next 10 years. I just go down the line there. So I'm in the orange table. Okay, so let's say I have other risk factors. I have a family history of premature coronary disease, then we would talk about possibly starting me on a statin. Or let's say I have other medical conditions that do increase the risk of disease, such as chronic kidney disease. I have this metabolic syndrome. I have chronic inflammation. I have rheumatoid arthritis. I have psoriatic arthritis, inflammatory bowel disease. All these things do increase the risk of future coronary vascular disease. So if I'm in that borderline range, it's better to treat early on to slow the progression of the disease rather than treat later on to minimize harm. Another important thing is when it comes to women, the gestational history is very important. Did they have a history of preeclampsia? Did they have early menopause later on in life? These are also strong risk factors for coronary disease. So in that case, we would possibly consider early initiation of statin, even at a lower level of LDL. If you look at the bottom, it mentions calcium scoring just down there. So that's a powerful tool that we have. And basically what it is we get a low dose scan of the chest looking for calcium. Calcium corresponds to plaque buildup. The higher the calcium, the more plaque we have. So that can sometimes help guide our management. Let's say you come into the clinic, you're kind of intermediate risk, you're not sure you want to start the cholesterol or not. We can get a calcium score, and if we see significant amounts of calcium, we'll be like, you know, you do have plaque buildup already, and that might help us decide on starting statin therapy early on. So it's a very powerful tool. It's a quick scan. It's something that we can do at Eastern Maine and can really, really help with stratify patients and optimize early medical therapy. So this is the calculator that I talked about, the ASCVD risk calculator. So we look at a couple of things. We look at sex. We put in the total cholesterol, HDL, your blood pressure, high-on blood pressure medications, race, age, smoke, and diabetes. And as I said, it gives us a percentage risk in the next 10 years. Sometimes we can also use it to give us a lifetime risk of coronary vascular disease, or 30-year risk of coronary vascular disease. So these are some of the medical conditions that can cause high cholesterol: chronic kidney disease, diabetes, HIV, hypothyroidism, lupus. Another important thing is there's medications. Medications can sometimes cause lipids to go up as well. Certain medications, for example, acne, the retinoids, especially oral form, can cause lipids to go up. Certain cancer therapies, high blood pressure medications, especially diuretics, hydrochlorothiazide, thiazide diuretics, beta blockers can cause our cholesterol to go up a bit. HIV medications, certain medications that we use for rhythms, heart rhythms, immune suppressants, sometimes these can cause the cholesterol to go up as well. So the next is talking about lifestyle changes and medications. So important lifestyle changes, exercise. Really, exercise is very important. It's recommended that we get at least 150 minutes a week of exercise where our heart rate goes up. So that could be brisk walking, for example. I would also add weight training is important because it does improve the strength of our musculoskeletal, our bone system as well. Another important thing is avoiding sugar and refined carbohydrates, losing weight, very important. Healthier diet, healthier fats, and also limitations on alcohol intake, and also minimizing or avoiding carbonated, sweetened drinks such as soda. So medical therapy. So I've just included these cartoons here. It's from a very good channel on YouTube called Speed Pharmacology. Excellent. But basically, we're going to go through the different classes for cholesterol medications. First of all, the medications that target LDL, and then we'll talk about the medications that target triglycerides. So statins really are the workhorse. They're the ones that we typically use for a high cholesterol. They include Crestor, Lipitor, Zocor, Pravachor, and they end with a statin, the name, the simvastatin, atorvastatin, rosuvastatin. Basically what they do is they work on an enzyme. I don't know if you can see the mouse, the cursor, but we have an enzyme in our liver called HMG coenzyme A. And basically the statin works on the pathway that changes this enzyme, changes this product to mevalonic acid. So in turn, what will happen is the cholesterol inside the liver comes down, and what that will cause these receptors, these black spikes, to be expressed. We get more receptors, so we're able to take more cholesterol out of the bloodstream. So that's how we reduce the number of LDL in our bodies, but it also has an effect on reducing this very low density lipoprotein, which will help reduce triglycerides in our bloodstream. So it works on reducing both LDL and triglycerides. The next medication, the cholesterol absorption inhibitors, the one that we have is ezetimibe. So basically it works on the inside of the intestines. We have a receptor here where the cholesterol binds to it, just above that penguin. And basically this receptor cholesterol complex binds with another complex, which causes it to be absorbed into the cell. So this medication, ezetimibe, prevents this change from happening, this complex to form. So prevents the absorption of cholesterol from our guts. And this causes the liver to produce more of these receptors and take away more cholesterol from our bloodstream. So it's kind of a complex pathway because it involves the intestines, the liver, the intestine, sorry, and the liver. So when you're not absorbing a lot of cholesterol, your liver will produce more receptors because you need the cholesterol for certain functions, as we mentioned. So in turn, that causes cholesterol to come out of the bloodstream. The other medication, nicotinic acid. So we don't use it much, but it works in a different method. So it works in the adipose tissues, the fatty tissues. It reduces the breakdown of triglycerides to fatty acids, which we use in the liver to produce a product with a very low density lipoprotein. So when we're not able to produce the very low density lipoprotein, it will end up reducing our LDL, and it can also increase our good cholesterol, our HDL. The mechanism is not known, but it does have a minor effect on that. This is bempedoic acid, or Nexletol, is one of the newer medications out there. It's similar to a statin, but it works on a step above statin, just here. And it's activated in the activated in the liver, so it's less likely to cause muscle problems. But it's not completely benign. It can still cause elevated liver enzymes. It can cause upper respiratory tract signs and symptoms. And one of the things that we worry about in these patients is the risk of tendon rupture. It's less than 1%, but if a person has issues, musculoskeletal problems, or if they're on certain medications or above a certain age, then we try and avoid this medication. But it really works fantastically well with a statin in really reducing cholesterol. Another older medication is the bile acid binders. And basically what they do, as we mentioned, cholesterol is used to produce bile acids. So these bind with the bile acids and you excrete them. And what tends to happen is your liver needs to make more bile acids. So it needs to use more cholesterol to try and aid in digestion. So you get more of these receptors. LDL attaches to it, is removed from the bloodstream. So your LDL levels come down. And then there's newer medications out there. The Psk9 inhibitors, we have 2 out in the market, the Praluent, Repatha, the other one. And they're very powerful lipid-lowering agents. And typically we use them mostly in 2 circumstances. One is if the patient is not tolerating statins and we can't really get the cholesterol down on other agents. Or if the patient is on statin, is on ezetimibe, for example, and their cholesterol is still high, is still posing a risk, then we introduce these medications to really bring down the cholesterol. So these are injectable medications. They're given every 2 to 4 weeks. And what they do is on the liver, this receptor, the LDL receptor, where the cholesterol binds to and then is taken into the liver, there's a molecule called Psk9. And what that does is it combines with this receptor and causes it to degrade. So what tends to happen in time is this Psk9 molecule will cause our LDL receptors to drop in number, and that causes our LDL to go up. So this inhibitor is a monoclonal antibody, works on this molecule, prevents it from adhering to the receptor, so the receptor can work normally, can get the LDL, take it into the liver, and come out again and take the other molecule. And then there's another medication, very new, called inclisiran. We haven't used it yet, but it's just as good as the PCSK9 inhibitors. And some people look at it as a cholesterol vaccine, basically. You go in, you get a short infusion every 6 months, and it really drops your cholesterol. But as I mentioned, we haven't used it much. I don't have much experience with it, but definitely a powerful new medication that we will be using more frequently in the future. So that was for high cholesterol. Now, in regards to high triglycerides, so statins, we still use it first line for high triglycerides because of the other effects, because we also want to bring down LDL, so first line therapy. And then another medication is the fibrates, the fenofibrate, such as Tricor. And what it does, it works on genes. So it upregulates one of its genes, which causes increased expression of an enzyme that causes more absorption of triglycerides from the bloodstream, so it results in reducing our triglyceride levels. Another medication is the fish oils, the omega-3s. The most powerful one is called Vasipa, and that reduces triglyceride, has no effect on LDL. There's another one as well, which can help lower triglyceride, but can increase the LDL a bit. It's called Lovasa. And it really just depends on what the omega-3 entity in it is in it. One acts more on LDL, the other one hasn't, one affects just the triglyceride, the other one has an effect on the triglyceride, but also the LDL. And in conclusion, sorry, I know I went over time. So really, lifestyle changes is key. healthy lifestyle, healthy diet, exercising, healthy weight, controlling your diabetes, controlling your blood pressure, avoiding cigarette smoking, avoiding processed food is just as powerful as medications. Healthiest diet, Mediterranean diet, especially if plant-based. The big advantage of it is sustainable, unlike a lot of other diets where we do it for a month or two, then we're tired, we stop, we gain the weight, and we're back to square one. Mediterranean diet is more a life changer. And medications should always be adjunct to healthy lifestyle. Maintaining bad lifestyle but taking medication really doesn't help much. They always need to come in tandem to really work and reduce the risk of cardiovascular disease. And that's it. Thank you for your attention.
Oh my goodness, Dr. Mansour, that was fantastic. And we have received a ton of great questions. We are thankful for Dr. Jansowitz monitoring that quote. That was that, Dr. Mansour, you should check out the chat. There's a huge list of great questions. So I want to thank all of our guests, all of our participants this afternoon, and also remind you that once we end this session, you will, oh, thank you, Brenda. You will receive a survey. Please take a moment and fill that out for us. We'd love to know how you heard about today's session and what your thoughts were about that. So again, thank you. We'd love to hear also about other topics that you would like to learn more about. So Dr. Jansowitz, did you want to say something?
Yeah, that was a tour de force on us. That was great. Really explaining, you know, really explaining, you know, that, you know, why we have cholesterol circulating around, why it's important for maintaining our health, but how things go off the rails when our levels are high. So I didn't get to a few questions at the end, which you and I will definitely answer here. So let's see, what did I not get to? So is there a connection between having the gallbladder removed and having high risk cholesterol levels due to heredity? So I think for hereditary factors, you know, some of us have high cholesterol partly as a genetic piece. So some of us are unfortunately just programmed to have higher LDL levels than some other people. We have some genetic either abnormalities or what we call polymorphisms. Our genes are different than someone else's. Does removing the gallbladder, what exactly does that do to cholesterol levels? That's a really good question. I do not know the answer as to, do you have an answer for that, Anas?
So I think it can have an effect on the absorption of cholesterol because so the gallbladder, the main function of the gallbladder is it excretes bile salts. And the bile salts are used to break down the lipids in our bloodstream. So, sorry, the lipids in our diet. So does it have a major effect on cholesterol, hereditary cholesterol? Probably not, but it can have an effect in reducing the absorption of certain components of our diet. The fat-soluble vitamins can be affected by that. And I wonder sometimes, I mean, it could possibly, I guess, have a small effect on the lipids. You may need to upregulate certain receptors so that you're able to synthesize inside the body a bit more lipids. But I don't think it really changes someone from, let's say, having normal cholesterol to having significantly elevated cholesterol down the line. I don't think so.
And then there was one more question that I didn't answer. Dr. Mansour mentioned monoclonal antibodies as an LDL increasing potential. Does that include Prolia? And that was from Jay Purcell. That's a tough question. I don't have the answer for that one offhand.
So let me just quickly denosumab. Okay, so I'm not really familiar with that. I know at the moment the ones that we have are PCSK9 inhibitors, but there's a lot of medications in the pipeline. coming out. So I don't really know the answer for that, but I guess we'll have to wait and see. But there's definitely that class of medications is just expanding. There's going to be monoclonal antibodies to help us reduce triglycerides. There's going to be ones that target Lp(a) and various other pathways of cholesterol synthesis. So I think things are continuously changing, but at the moment, I'm not really, I don't know what the answer for that is.
I think we're at time right now. There was a nice question about VLDL and LDL as well. I will try to put in a link for that. And there's just a bunch of great questions. So awesome presentation, awesome questions. I am so sorry that I wasn't responding to everyone. Some of you may have seen me like typing away furiously and you weren't seeing answers. And then thankfully, Amy let me know that we had a problem, Houston. And so I just started copying and pasting in. So I apologize about the delay there. And I will put in one more link. Thank you, everyone.
Thank you so much, Alan. And yeah, I'll take a look at the questions as well. And try and answer as many as we can.
Wonderful. Thank you very much to both of our panelists today and to everyone who joined us. We're appreciative of your time. Thank you so much. And I think I'll just keep the recording going for a few more moments as you gentlemen possibly answer some more questions, just so that I ensure it'll get on the video.
That sounds good. Thank you so much, Amy, and thank you everyone for spending the time and joining us today.
Thank you. Have a good afternoon, everybody. So Joanne, I don't know if you're still online, but the survey should be emailed to you as soon as I end this session. And I don't want to end it quite yet, as our subject matter experts appear to be still typing frivolously. So it will come to you as soon as you're welcome. Yeah, as soon as we end. It's good.
I think that we covered them. There's a chance that I missed something in there, and thank you so much for letting me know that my answers weren't getting out. You must have seen me typing like crazy, and you weren't the only one seeing them.
Well, I was seeing them as the host. They were coming up, and I'm thinking, either he's texting his friends or he's trying to tell.
Goodness.
That's okay.
Okay.
It was a great recovery, and I'm confident that the responses were received.
Excellent. Have a good one, and Anas, thank you so much.
Thank you so much for helping today, Alan. Thank you, Amy, for giving me the opportunity. And remember, lifestyle changes very important, just as good as medications.
Good advice. Thank you.
All right,
have a good afternoon.